بسم الله الرحمن الرحيم. هنتكلم عن surgical jaundice in children. In this lecture, we will talk about jaundice, hemolytic jaundice, obstructive jaundice, and diagnosis of jaundice. Jaundice is a yellowish discoloration of body tissues and fluids due to deposition of bile pigments. In neonates, jaundice occurs with total serum bilirubin more than 5 mg per dl. With hemolysis of RBCs, heme is released. It changes into biliverdin, then unconjugated bilirubin. Unconjugated bilirubin in the liver change into conjugated bilirubin. Then it passes to the gastrointestinal tract, where it is partially excreted with stool as stercobilin, partially excreted with urine as urobilin, and partially passed to the circulation as unconjugated bilirubin to the liver again in intrahepatic circulation. Jaundice could be prehepatic, hepatic, or posthepatic. Prehepatic due to increased bilirubin load, hepatic due to impaired bilirubin conjugation, and posthepatic due to impaired bilirubin excretion. Common causes of jaundice in newborns: physiological, APO or RH incompatibility, intrauterine infection, breast milk jaundice, Gilbert and circular Najjar syndrome, biliary atresia, choledochal cyst, inspecific bile plug, cephal hematoma, and intraventricular hemorrhage. In children, the common causes are blood diseases, infections, drugs and other toxins, hypothyroidism, metabolic and autoimmune disorders, and obstructive jaundice as choledochal cyst and bile duct stones. The common causes, in general, the common causes of surgical jaundice in children are hemolytic jaundice and obstructive jaundice. Hemolytic jaundice due to blood diseases as thalassemia, sickle cell disease, hereditary spherocytosis, and obstructive jaundice due to biliary atresia, choledochal cyst, and inspecific bile. We will start with the hemolytic types. Hemoglobin. The hemoglobin molecule consists of 4 heme groups and 4 globin chains. The globin chains are alpha, beta, delta, and gamma. Deletion or mutation of the genes controlling globin synthesis will make abnormal hemoglobin and blood diseases. So these are the normal the chains which is forming the different types of hemoglobin. In hemoglobin B, which is the main hemoglobin in adults, consists of 2 beta and 2 alpha. In hemoglobin A2, 2 alpha and 2 delta. In hemoglobin F, which is the main hemoglobin in the fetus, 2 alpha and 2 gamma. We will start with the first type of hemolytic jaundice due to thalassemia. Beta thalassemia major is an autosomal recessive genetic blood disorder which occurs in homozygous individuals where no synthesis of beta chains, so there is absence of hemoglobin A1. This results in an abnormal RBCs which have poor oxygen carrying capacity and excessively destroyed by the spleen. Clinically, there is growth retardation, short stature, serotemic facies, muddy complexion, pallor, and splenomegaly. The complications are gallbladder stones, hemosiderosis, endocrine disorders. Treatment of beta thalassemia consists of transfusion therapy, and the rule of surgery in the management is splenectomy. Splenectomy is indicated when frequent transfusion is needed to maintain hemoglobin percent and with huge spleen. The second type of hemolytic jaundice is sickle cell disease. Sickle cell disease is an autosomal recessive genetic blood disorder occurring in homozygous individuals. The normal hemoglobin A1 is replaced by hemoglobin S. This type of hemoglobin under hypoxic condition crystallizes and distorts, elongates the RBCs to have the sickle shape. This increases the blood viscosity and obstructs the blood vessels. This is the normal, and this is sickle cell disease. Clinically, there is delayed growth, anemia, jaundice, splenomegaly, hemolytic crisis, splenic sequestration crisis, vaso-occlusive crisis, and acute chest syndrome. The treatment of sickle cell disease is transfusion to treat anemia, and during crisis, IV fluids, analgesics, and corticosteroids. Splenectomy is indicated for frequent sequestrations and huge spleen, and cholecystectomy is indicated for gallstones. The third type is spherocytosis. This is an autosomal dominant hemolytic disorder with a defect in RBC's cell membrane. So the RBCs will be small and sphere-shaped, and these abnormal RBCs have abnormal osmotic permeability and lack deformability. This will cause easily sequestration and more liable to hemolysis. Clinically, there is jaundice, splenomegaly, and there is hemolytic crisis. The treatment of hereditary spherocytosis is mainly by splenectomy. Why? Because it decreases the sequestration and destruction of RBCs in the spleen. The effect of splenectomy is to increase the lifespan of RBCs when it's to be done at the age of 6 to 7 years. Now we will talk about the obstructive jaundice. The first is biliary atresia. Biliary atresia is obliteration or absence of the bile ducts. It may occur. There are two types: embryonic, which occurs due to during differentiation of hepatic diverticulum, and prenatal, which develop later in gestation, and it is progressive. The types of biliary atresia are: type 1, there is atresia of CBD; type 2, there is atresia of CHD; type 2B, there is atresia of CBD, CD, cystic duct, and CHD. Type 3, there is atresia also the same like this, but this is atresia is up to the porta hepatis. This is a photo of biliary atresia. Clinically, the baby is initially active, then develop malnutrition, anemia, growth retardation. There is jaundice since birth, which much increase in weeks. There is abdominal distension by the enlarging liver, later by ascites and splenomegaly. The stool is clear colored, urine is dark colored. The investigation is by ultrasonography. First, ultrasonography. Ultrasonography will show the characteristic triangular cord sign. This well-defined triangular area present at the porta hepatis due to the fibrotic ductal remnants. Other investigations are the CT scan, intra-aortic cholangiogram. This is the CT scan. This is normal because the dye pass from the liver into the bile ducts. Here, there is no passage of the dye. This is normal. Here, there is no passage of the dye from the liver. So this is biliary atresia. Treatment is by preoperative management, preoperative preparation. The treatment is surgical. Surgery is to be performed as early as 6 to 8 weeks before biliary cirrhosis becomes evident. Kasai operation is the usual treatment for this case. It is a hepatic portoenterostomy. A row in Y jejunal loop is anastomosed to the extrahepatic biliary tract at the porta hepatis. And liver transplantation is considered when Kasai fail or when there is late presentation of the cases. This Kasai operation, this is biliary atresia. Here, this is the row in Y. This is the jejunal loop anastomosed to the extrahepatic bile ducts, the remnants of the hepatic ducts, and this is the Y anastomosed. Colorectal cyst is a rare congenital anomaly where there is abnormal dilatation of the bile ducts. The types are Type 1, there is cystic dilatation of CPD. Type 2, there is CPD diverticulum. Type 3, there is coludococele at the terminal end of the CPD. Type 4, there is intra and extrahepatic and intrahepatic dilatation of the bile ducts. And type 5, there is intrahepatic dilatation of the bile ducts. This is what's called Caroli disease. This is coloducal system. Clinically, the classic presentation is by obstructive jaundice, abdominal mass, and abdominal pain. However, there is variation of the presentation according to the age of the baby. The investigation is by laboratory ultrasonography, which show the cyst, and also ERCP, MRCP, PTC, and the CT scan. This is MRCP showing the cyst. This is ERCP showing the cyst. This is PTC showing the cyst, and this is the CT scan. And this is classification according to the presentation on contrast study. The treatment is surgical by excision of the cyst, and then reconstruction of the biliary system, the biliary ducts, by hepatoduodenostomy or hepatojejunostomy, as in this photo. The third type is inspecific bile plug syndrome. This is at resistant jaundice in newborns with hemolytic anemia or sepsis due to obstruction of the bile ducts by inspecific bile. The treatment here, inspecific bile obstructing the bile ducts. The treatment is by percutaneous transhepatic flushing of bile ducts, and rarely surgery may be needed to clear and flush the bile ducts. Diagnosis of jaundice in children is made by history, and we have to remember that jaundice in the first day of life, before 24 hours, is always pathological. Physiological jaundice occurs after 24 hours. By examination, jaundice, sign of sepsis, abdominal mass, evidence of trauma, hypothyroidism. By examination of the color and the character of urine and stool. By investigations, liver function tests, radiological examination, investigations, ultrasonography, ERCP, MRCP, PTC, CT scan will help to visualize the abnormality. And in summary, jaundice is a yellowish discoloration of tissues and body fluids due to excessive bilirubin, may be prehepatic, hepatic, or posthepatic. Jaundice could be physiological or pathological. The latter may be due to medical causes or surgical causes. Biliary atresia, coloducal cyst, and inspecific bile plug are common cause of obstructive jaundice in children. Beta thalassemia, sickle cell disease, hereditary spherocytosis are hemolytic body diseases, blood diseases associated with jaundice, and the surgical intervention could have a role in their management. Thank you.